Welcome to the podcast on critical thinking related to complex care of older adults. This podcast was created by the University of North Carolina at Wilmington School of Nursing, based on content authored by Maddie Mezzi and Dina Gray-Maselli, in collaboration with the University of North Carolina School of Nursing students. The learner objectives for this podcast include being able to identify the elements involved with a person-centered approach to clinical decision-making with older adults with complex illness, to be able to identify caregivers' readiness to care for older adults with complex illness, transitioning to home, the nursing home, or subacute levels of care, to develop a plan of care along with an older adult with complex illness that promotes autonomy, to set realistic goals along with the older adult that takes into consideration personal choice, cultural diversity, and/or decisions about quality of life, and to be able to apply knowledge from theories of behavioral change to understand patient choice, decisions made related to care, and adaptation to an intervention. Caring for older adults is both complex and challenging. It is complex because of the array and number of chronic illnesses facing older adults, which is only expected to increase with longevity. Nearly 90% of people over the age of 65 have at least one or more chronic conditions, with the average 75-year-old experiencing at least 3 chronic illnesses. It's also challenging given the demand for skilled healthcare providers in geriatrics or gerontology, which far exceeds the capacity of the current geriatric nurses and other healthcare professionals. The burden of chronic healthcare continues to fall on all healthcare providers, especially nurses. Healthcare institutions, family caregivers, and older consumers themselves also share this burden. Therefore, we envision healthcare professionals in all healthcare settings, educators, and new students entering nursing to question, am I prepared to provide the very best geriatric care when called to do so? So setting aside all of the complexities and challenges to geriatric care, we know that older adults experience positive health outcomes when certain evidence-based nursing assessments are made, certain evidence-based nursing management approaches are followed, and certain evidence-based system approaches are provided. We also know that in order to impart quality health care to all older adults in all healthcare setting encounters, nurses must consistently draw upon a standard set of skills. Similar to other disciplines, this set of skills routinely requires critical thinking, applied at varying dosages depending on situational context and healthcare issues identified. Let's first consider a case study to organize our thoughts. Throughout this presentation, we will be referring back to this case study in order to digest steps towards critical thinking in the complex care of an older adult. Miss Lee is a 96-year-old retired child psychologist who lives alone in a one-bedroom studio apartment located in a continuing care retirement center. She is single, never married, and has only one close friend. Miss Lee spends most days reading and caring for her pet cat. She has stopped daily walks outside because she refuses a cane, because that's for old people, she says. She has become quite forgetful, according to the staff, and the physician has requested a home visit to check on her, check her blood pressure, and review her medications. Miss Lee greets you at the door with her pet cat and invites you in. Her apartment is cluttered. On the kitchen table are medications spilled out in their containers. A fan is blowing in the background, absorbing the smoke from a recent burnt pot. Miss Lee remarks that she is fine and feels great, although she does admit to a poor memory on occasion. She uses a tape recorder to remind her of important things. We also learned that Miss Lee was the middle child of 3 girls, and both siblings died of breast cancer. Her father died at age 80 from cerebral strokes or an aneurysm. Her mother died at age 60 from ovarian cancer. Miss Lee has a history of coronary artery disease, cardiac arrest secondary to supraventricular tachycardia, atrial fibrillation, hypertension, hypercholesterolemia, and Parkinson's disease, managed by the noted medications. On the initial history, you learn these facts. Miss Lee is complaining of recent frontal headaches, occasional dizzy spells, and possible blackouts. She's experiencing multiple falls every day and has numbness of the left arm and left leg. Functionally, she has increased difficulty with her walking, and she's dragging her left leg. She's independent with toileting, dressing, and bathing. On physical exam, her blood pressure is 180/98, her apical pulse is 60 and irregular, her respiratory rate is 18. On breast exam, she has a discrete nodule mass at 2 o'clock in the left upper quadrant of the right breast. Her abdomen is soft and non-tender, her lungs are clear, Neurologically, she is exhibiting slurred speech, left-sided weakness, her balance is unsteady, her gait path deviates and leans to the left, and her mini-mental status is 27/30. This is the first of 5 recommendations that should be utilized in treatment and planning of elderly care. Adults with advanced age and complex illness should be helped to conduct advanced healthcare planning and make decisions as they relate to their current assessment, the results of any diagnostic testing, and treatments for chronic condition in light of the older adult's life expectancy, their functional status, their physical and their cognitive status, their desired quality of life, and the availability of social supports. Because practice with older adults covers a wide range of possible ages, from 65 through over 100 years of age, nurses must target plans of care individualized to the older person's age, the presence of chronic illness, and the complexity of healthcare issues. The process of critical thinking allows nurses to realize that the plan of care for a 90-year-old with chronic illnesses, in all likelihood, should be different from that of a 75-year-old with the same illnesses. Further, nurses must ask, how does the nursing plan of care effectively factor in advanced age, presence of comorbidities, and the risk of geriatric syndromes? So in thinking about the decision-making of adults with advanced age and complex illness, adults who demonstrate full decisional capacity are free to make their own decisions about care, no matter what the risks are associated with that decision. And family members should not be approached when an older adult has the capacity to make a decision, even if it's a bad one in your opinion, no matter what their age. Such decisions might include testing, referral or seeking additional assistance in complex treatment decisions. Communications with patients and families should center on the type of outcomes they desire and consideration of care that allows for maximum physical, functional, and social independence, maintenance of autonomy, safety and security, and reducing risks while acknowledging individual personal choice along the care continuum. Important overarching considerations guiding healthcare decisions are the quality of life for the years of life remaining. To determine decisional capacity, the following principles should guide the process. Older adults are presumed to have decisional capacity until proven otherwise. Capacity is a clinical determination. Assessment instruments such as the mini-mental and mini-cog are helpful, but they do not determine the capacity to make a decision. Capacity is decision-specific. Older adults may demonstrate capacity to make some, but not all, treatment decisions. Capacity is not an on-off switch. Rather, it should be viewed as a dimmer switch, with most older adults able to demonstrate capacity to make some, but not necessarily all, healthcare decisions. The greater the consequence of the decision, for example, amputation versus food choice, the greater the need for clarity as to the older adult's decisional capacity. Guidelines exist for a valid and reliable way to determine an older adult's decisional capacity to execute a healthcare proxy. In general, these and other capacity determination guidelines are based on the process of informed consent. The elements of the process of informed consent seek to assure that an older adult demonstrates the ability to make a choice, understanding, by repeating in their own words the information that was given, the ability to weigh options, showing an understanding of the consequences of a decision, and consistency, by making the same decision at 2 or more points in time. It is important to keep in mind that, as with all adults and decisional capacity, older adults have the opportunity to take risks, to make decisions with which other family members and healthcare professionals may disagree, and to make decisions that, from the perspective of the healthcare professional, have a high likelihood of failure. Older adults should have the opportunity to make healthcare decisions that have both serious consequences as well as day-to-day consequences. The premise of collaborative management is to ensure that effective medical, preventive, and health maintenance interventions take place. 4 strategies have been identified for collaborative management of chronic illness. The first is to define the problem, have the patient define their problem, and to compare these against their medical diagnoses. Goals need to be set, and then the plan of care begins to be executed. This is done along a continuum which provides opportunities for teaching patients skills to manage their disease, as well as to guide behavioral change and to provide emotional support. What is planned for today may not be what the plan needs to be a week from now, so it's important to remember and to remind family members that this is not a black or white issue, it's a continuum of care. We also need to evaluate and monitor the health status and to identify complications while checking on progress along this continuum of care. In the example of Miss Lee, at 96 as a healthcare provider, it may be alarming that she's not had a mammogram since she was 90 years old with a family history of cancer. Miss Lee, on the other hand, may not see this as a problem. Her only problem may be that she's having difficulty cooking and managing her household affairs. So in reflecting on the history for Miss Lee, what would a Folstein Mini-Mental score of 27 out of 30 indicate? And in considering her decisional capacity, the Mini-Mental of 27 is a measure of higher cognitive function and is a normal score, indicating that Miss Lee has an intact memory, language, calculation, and reasoning abilities. Adults with advanced age and complex illness should be considered at risk to develop adverse responses and complications related to medications, geriatric syndromes, and treatments that have been administered. Some reasons for adverse effects include age-related pharmacokinetic and pharmacodynamic changes, drug-nutrient interactions, drug half-lives, the older person's body weight, their hydration status, their albumin level, and their frailty. In addition to medication interactions, geriatric syndromes increase the risk of complications. Some of the geriatric giants of geriatric syndromes include pressure sores, cognitive impairment, gait instability, falls, urinary incontinence, and sleep disturbances. Geriatric syndromes primarily refer to one symptom or a complex of symptoms resulting from multiple diseases and risk factors. Please note that geriatric syndromes and medications overlap in their ability to affect the care of an older adult. In thinking back to Miss Lee, based on our interview with her, which included a physical assessment, what geriatric syndrome does she possess that places her at high risk for a serious injury or fatality? Miss Lee is at greatest risk for fall with a serious injury. In reviewing her medications, also discovered that she's on Coumadin, which is a blood thinner. Given her multiple falls and left-sided weakness, she could have had a recent cerebral bleed, possibly due to a stroke or subdural hematoma. For her initial plan of care, based on the problem list and Miss Lee's risk for falls with a serious injury, you and the physician believe that it's important to determine the underlying cause of the falls, which appear to be multifactorial, so that you can treat them appropriately. This would include further tests such as a carotid Doppler ultrasound, an MRI of her brain with a contrast. This would help us to rule out a stroke or hematoma, and a 24-hour EKG, blood work, and a mammogram. You propose this to Miss Lee and state, "We can take care of all this at once we get you admitted to the hospital." Miss Lee refuses to go to the hospital and wants to be left alone. You explore this further, and she has many rational statements as to why she does not want to go, but wants to die at home. Again, this is another example of where, as a healthcare provider, we have determined what we think the problem is, and Miss Lee has a different opinion about what the particular problem is. This brings us to recommendation 3. Adults with advanced age and/or complex illness should be viewed as an at-risk population. In delivery of health care to older adults with advanced age and complex illness, nurses should ask themselves, what might this older adult be at risk to develop? If we can minimize risk, then we can improve health outcomes. Frailty is an outcome of chronic illness and/or functional limitation among older adults with advanced age. Multiple chronic conditions are criteria for frailty and place older adults at greater risk. There is no universal consensus for a definition of frailty, but generally it's regarded as a dominant determiner of ill health, attributed to both loss of physiologic organ reserve with age and chronic illness believed to accelerate its development. Specific and recognizable signs and symptoms based on physiological changes include unintentional weight loss, symptoms of exhaustion, slow walking speed, grip weakness, and low physical activity. Frailty has been shown to increase with age, be greatest in women, and more commonly seen in African Americans and in persons with lower education, income, poor health, and higher rates of disease and disability. Frailty is typified by a gradual progression over months or years. The fact that a pre-frail state exists suggests that interventions for prevention of a full-blown frailty can be identified, and those at risk targeted for specific interventions can avoid its onset, or at least delay it. Not only is frailty important to recognize, it must be responded to if quality healthcare outcomes are to be achieved. Progressive resistance exercise training, along with multi-nutrient supplementation, reduced overall frailty in an intervention group of 100 frail elderly nursing home residents over a 10-week period, as evidenced by increased muscle strength, increased gait velocity, and increased stair climbing power. Given that over 70% of hospitalized older adults are able to walk, did not do so during a 3-hour period, leads one to ask, why do patients continue to have orders for bed rest despite evidence of adverse effects, and why don't hospitals make ambulation a focus of this work given the speed at which functional decline occurs in the elderly? This brings us to the third question in our case study. Did the workup that was proposed factor in Ms. Lee's advanced age and current life expectancy? Ms. Lee has outlived her projected life expectancy by several years. It is unlikely that the benefits of discovering the etiology and treating it will significantly improve her life expectancy, but it may improve the quality of her life remaining. The question becomes, would the associated risk of undergoing this aggressive workup jeopardize or impair the current quality of life she's experiencing? Hospitalization carries inherent risk of nosocomial infections, iatrogenic complications such as acute confusion, and the possibility of a functional decline. These are important factors given Ms. Lee's desire to stay at home and to not go to the hospital. This brings us to recommendation 4. In planning nursing care, adults with advanced age and/or complex illness should be assessed for functional and cognitive status, pain, and geriatric syndromes, for example, delirium, fall risk, the presence of urinary incontinence, or pressure ulcers. And this is irrespective of the setting in the hospital, whether it's in the emergency room, the oncology unit, or the critical care unit. Strong evidence exists that nursing assessment of adults of advanced age, which consider their intra-individual heterogeneity relative to physical, emotional, functional, and cognitive capacities in the hospital, yields positive outcomes related to the patient's mortality, morbidity, and length of stay. Many designated high-risk conditions, frailty, cognitive impairment related to delirium, depression, functional impairment, urinary incontinence, and pressure sores, can be assessed by using standardized measurement tools that can be found at consultgerirn.org through the Try This series. For example, the Confusion Assessment Method, the CAM, the Urinary Incontinence Assessment with a bladder diary, the Fall Risk Screening, the Heinrich Fall Assessment, recognition of dementia in the hospitalized older adult, the executive dysfunction, or other geriatric topics such as pressure sores, depression, delirium, dementia, and falls. So for question 4 of our case study, of all the tests considered, which one holds the greatest promise for reducing further risk for serious injury and potentially improving Ms. Lee's quality of life? Of all the tests that were considered, the MRI of the brain could be the most useful in determining if there is a subdural hematoma or a cerebral bleed from the Coumadin. The Coumadin could be switched to an alternative, less potent antiplatelet agent. This brings us to our final recommendation. In planning nursing care, adults of advanced age and/or with complex illness should have access to hospital system-based models of care, which include perhaps a geriatric resource nurse or an ACE unit, which is the acute care of the elderly units, and case management known to implement strategies that prevent geriatric syndromes. For example, limited or no use of physical restraints, early and consistent walking and ambulation programs, removal from pharmaceutical formularies of medications known to cause high adverse drug events, such as the Beers criteria, and early treatment of functional decline and cognitive impairment due to delirium, depression, and dementia. Shortly after your last encounter with Miss Lee, she became bedridden and died peacefully in her home with her pet cat and close friend at her side. She told you before passing on that she was very comfortable and would not have chosen any other alternative. This was comforting news to you and the rest of the healthcare team. So our take-home points are that the presence of multiple comorbidity, functional declines, and advanced age all impact on nursing decision-making and management of complex illness in older adults. Key gerontological nursing concepts influencing nursing decision-making with older adults include respect and promotion of individuality, autonomy, personal choice, and independence. So in conclusion, geriatric nursing is a distinct specialty of nursing legitimized by its own standards and scope of practice and a set of nationally recognized competencies for which clinical care is to be delivered. Clearly, these written works speak to the specialized skill, knowledge, and competencies that must be practiced when providing quality health care to this population. In the 5 recommendations presented, we make a clear distinction for nursing care of older adults with advanced age and comorbidities. This population of advanced old age typifies now and for the future the bulk of our health care delivery efforts. Shifts in the nursing process and plans of care, which clearly earmark interventions directed at the primary and secondary prevention of frailty, functional decline, and geriatric syndromes, are therefore required in order to truly meet the needs of this population. In order to do this successfully, nurses working with hospitalized older adults must continually critically think about improving patient outcomes by reducing the burden of these healthcare problems during individualized and team assessments of older adults. Geriatric care is best delivered when certain principles are incorporated, certain practices are followed, and certain system-wide approaches are adopted. Elements in the delivery of care include staff that are knowledgeable, committed, and dedicated in the care of older adults, that there is patient and caregiver education, that there are resources and models of care that address specific geriatric practice issues, that coordinated, collaborative, and continuous communication of care is conducted, and that there's a continual reassessment of the program.